Good evening to everyone present here with us today. This is Sriyan from IGCP. I will be your moderator for today's session. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Manoj Toshniwal. Sir is MBBS, MD Internal Medicine, DM Clinical Hematology, BMT Fellowship, Consultant Hematologist at Jeevan Amrut Hospital, Aurangabad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is newer treatment option in thalassemia. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
So, thank you so much for your kind introduction. I thank IGCP Group for organizing these medical seminars regularly. It's really a pleasure to be associated with something which is such a clinically relevant and useful in today's world. I'm Dr. Manoj Toshniwal. I've done my MD Medicine, followed by BM in Clinical Hematology, followed by Fellowship in Bone Marrow Transplant at Tata Memorial Hospital, Mumbai, and BCCA, British Columbia Cancer Institute, Canada. I'm right now working as consultant hematologist and bone marrow transplant physician at Jeevan Amrut Hematology Center, Aurangabad, Maharashtra. Today, we will be discussing on treatment updates in thalassemia. Last time we had a very good discussion on pancytopenia and before that thrombocytopenia. It was lab oriented topic. Today I thought let's discuss something which is straight away for one disease, that is thalassemia. There are many exciting things which are coming into the picture when it comes to the thalassemia. So today's topic of discussion will be thalassemia. First of all, I thank all of you for being available in today's session. It's a weekday, busy OPD day, and still you have taken time to listen something which is clinically relevant. I'm no one who is expert of anything. You all are experts because you see such busy OPDs where long queues are there. You are practicing there since many months, many years, many decades. You have seen thousands of patients. I know a little bit more about this thalassemia, and that is why I'm standing on this side of discussion. During this discussion, if you have any question, please feel free to type that in question and answer box or keep it that for the last so that at the end of discussion we will discuss about the question and answers. This is something which is a focused CME we all are doing, that is on thalassemia. Only one disease, and in that also we will be talking about treatment updates on thalassemia. Just to understand what thalassemia is, why we are attending, because we all want to learn about that particular disease. We all know thalassemia, and that is why we are here today. And the reason is we want to learn more about this thalassemia. We want to learn more about thalassemia, whether I have someone who is related to me who is suffering from thalassemia, or a patient who is coming to me regularly for the reason being he is having thalassemia. I want to take care of thalassemia kids in a better way. Already I am running a thalassemia daycare center. Already I am in some government setup where thalassemic kids are coming for the regular blood transfusion. And I want to improve that care, give them something which is concrete, long term, and that is why I am attending this session. Just because some friend has posted and said that let's attend it, sometimes it is because of the just attending. Today, whatever may be the reason, let me take that opportunity to discuss future of thalassemia. So newer treatment updates, that is future of thalassemia. Thalassemia, we all know, is very dreadful disease. Since ages, it has remained like a curse to the patient. Once someone is diagnosed with the thalassemia, usual timeline for them is just to take blood transfusion every month, get affected by the transfusion related iron overload, and with time, their medical condition keeps on deteriorating, and by the time they become mature adult, they are ready to leave this world. That used to be the past history of thalassemia. But now, today, it doesn't look like the same way. We are changing this. We are erasing that past and we are going to the very bright future for this thalassemia. Yes, there is still a very long way to go, but we want to change this picture from regular blood transfusion taking thalassemic kids to the someone who is bright, beautiful, who is running around and going for full of life. That is what we all want. More importantly, why this sea change is happening? Because we are moving from independent expert opinion to evidence-based scientific practice, which gives a better care to these kids who are suffering from the thalassemia. We are now looking to a total patient population rather than just treating an individual case. This is an evolving change in the thalassemia management. This is actually the treatment update which needs to be appreciated. This change in last 5 years in the management of thalassemia area. We are considering patient status today, or we are considering patient's journey until today. That is what we. Up till now, we were just managing iron overload. Now we are managing iron overload profile with individual organ. We are nowadays treating humans rather than treating patient by giving them all the possible support. And most importantly, we are now treating them as a team rather than as a physician, where everyone is involved into the care of that particular kid. What used to be the conventional therapy, rather, up till today also, this is the conventional therapy, except we are managing it in a better way. That is, regular blood transfusion with packed RBCs to correct the anemia, iron overload monitoring, and iron chelation whenever there is iron overload, more than 10 blood transfusion, more than 1000 ferritin, anything is there, you start with the chelation. Some patients do need splenectomy with time when there is symptomatic hypersplenism, supplementation of various minerals like calcium, vitamin D as and when needed, monitoring various disease complications and their treatment, and something like psychological support. This is the conventional therapy we all are managing. But now this has been changing. Initially, it used to be just iron overload management and regular transfusion. But with improvement in our knowledge about the metabolism of iron, with improvement knowledge about the genetic changes in the thalassemia, with availability of more and more transplant, now we are going towards the gene editing, better management of ion chelation, and something like curative therapy for these deadly diseases. I will be talking on these main 4 treatment updates in these patients with thalassemia. One is better chelation. Yes, we have come up with better chelating agents now. Hematopoietic stem cell transplant. Yes, these transplant facilities are available in many cities. More than 150 transplant centers are there all across the India now. Many of them are getting out of it by doing transplant. Some new drugs are there which are there for these patients, like luspatercept, which stimulates the erythroid maturation and reduces the transfusion requirement to almost zero. And very exciting thing, that is gene editing or gene therapy. Just one pill and you will be cured of this disease. That is something just at the horizon. I'll be talking about. Chelation has always remained the most important part in the overall care, overall growth, overall longevity, overall betterment of these thalassemic kids. They have to be on regular blood transfusion. Regular blood transfusion will be there for them, but with transfusion, there is always iron deposition in all the organs. And iron deposition is something which causes them the problem for life. And that is why we need to chelate that iron in a better way. Since 1968, we had just one molecule which used to be IV, deferoxamine, for subcutaneous or IV infusion, and it to be very toxic. But then came this 2005 and 2011 molecules, deferasirox and deferiprone. They were like near complete iron chelators, but some side effects were there, like GI disturbances and palatability issue. With that, now we have these film coated tablets. These are just once daily pill, can be given to the maximum dose, easily palatable. At any age group, it can be given. So, yes, we are coming up with very good iron chelators for these patients who are suffering from thalassemia, regular blood transfusion, and huge iron overload requiring chelation. Second thing I am talking about is this new drug which is luspatercept. Luspatercept is now available in the market in the Western world, also in the Indian market, which needs to be imported, and it helps just as a subcutaneous dose, 1 milligram per kg once in 3 weeks, and it makes them transfusion free. This drug is something very exciting. It works as selective human ACT receptor ligand or the trap, and it helps in erythroid maturation. It helps in maturing erythroid cells and making more blood, and they become less transfusible. Non-transfusion NTDT thalassemia are getting very much benefited by these drugs. At present, they are still in working. They are still expensive, but soon they will be available easily. They will be cheap, and transfusion requirement will be very less. Third thing which comes into discussion is hematopoietic stem cell transplant. We all know for now only curative therapy for these patients is bone marrow transplant. With availability of matched sibling donor, we all know success rate is good. Very well chelated patients who are managed with very good blood transfusion, more than 90% cure rate. But many of them don't get the matched donor. But now we have haploidentical and match untreated bone marrow transplant. There are many centers who are doing the transplant. Success rate is as good as 90% for these patients. These are few studies in recent past where overall survival rate is approaching almost 100% for haploidentical transplant with post-transplant cyclophosphamide and some other immunosuppressive agents. More than 100 patients they have treated, and looks like, yes, with or without CD3 plus CD19 depletion, we can achieve a very good success rate if the center is well equipped for half-match bone marrow. For transplant, main hurdle was donor, that is now on. Also, main hurdle was funds, and we have various government and non-government agencies which are ready to fund these patients for making transplant available. And that is also one thing which is keeping them moving towards the transplant with more confidence. So with availability of more funds, transplant centers being more, transplant quality being improved, almost more than 80% are getting cured, whatever may be the age, whatever may be the age, whatever may be the stage, whatever may be the finances. Yes, it is a very good curative. And last thing at the horizon now is the gene therapy or gene editing. We all know that this is the disease which is genetic. And now, with these various genetic agents, we have very good cure rate for these patients who are thalassemia. Considering the overall time phase required for the maturation of the data, maybe in next few years, we all will have these vectors available to us with lentivirus vector or some other viral vectors or non-viral vectors. This gene therapy will be available to our patient or the curative option, and it will be cheaper also with time. So, just to understand the future landscape of the thalassemia treatment, yes, thalassemia is a dreadful disease. Yes, thalassemic patients are always compromised, but now there are good days. We can prevent complication by improving oral ion chelation therapy, by giving better drugs like film coated tablets or subcutaneous or IV effervescent, early control of complications through regular follow-up, treatment, and other things. We do have this ineffective erythropoiesis controlling agent like JAK2 inhibitors or activin activators, luspatercept like drugs. With this, the care is improving. Better transfusions, better chelation, and less transfusion requirement by these newer drugs. And we are looking forward for curative options like stem cell transplant. More and more centers are there which are coming up for the transplant. More and more experiences they are now generated with haploidentical match unrelated donor transplant with great success rate, and also gene therapy is at the doorstep now. Soon we will be having gene therapy with us, where just one treatment session and patient by gene editing is cured out of the transplant, cured out of the thalassemia. So yes, this all from me for these kids today. Thalassemia is dreadful disease, but looks like future is very bright, and we are looking forward for the same. Thank you so much.
Thank you, sir, for your wonderful presentation. So, we have some question if you like to take that up.
Yes, please.
So, sir, the first question from our audience is: are there specific genetic or clinical markers that can guide treatment decision?
A very important question when it comes to the thalassemia. Thalassemia is a genetic condition, and usually initial genetic makeup of that patient is needed to understand whether the sibling will be affected or not, and for the in vitro or even intrauterine, what you call diagnosis. Also, for the gene therapy, some genes are vulnerable to gene therapy, some are not. So, for that reason, also, yes, some genetic markers are made. But when it comes to the overall care of thalassemic patients, it doesn't matter what genetic makeup is there. It is usually the phenotypic makeup that is what matters. If patient has needed transfusion early in the life, less than 2 years of age, they need transfusion more frequently. But if that transfusion was delayed, we can give trial of newer drugs like luspatercept or even thalidomide, hydroxyurea, and all these drugs help in effective erythropoiesis so that transfusion requirement can be. These are called as thalassemia intermedia or non-transfusion dependent thalassemics. They can be treated better depending upon the phenotype of the patient rather than the clinical judgment rather than the genotype of the patient. This is all. Thank you.
Next question, sir: how do factors like donor selection or conditioning regimen impact the success of transplantation?
Very, very, very important question. Yes, for thalassemia, bone marrow transplant remains the most curative therapy. Success rate if age is less than 10 years, if hepatomegaly is not there, if patient is well preserved by adequate ion chelation, and patient has a better match donor, that is full match donor, is always around 90%. With all these factors in mind, if one by them is getting compromised, the success rate of transplant becomes less and less. And that is why the donor type, the overall patient condition is important. Depending upon the overall patient condition also, the conditioning regimen for that treatment changes. Sometimes patient is in good shape, we can give a better conditioning regimen. But if already liver is compromised, we have to compromise on the various medicines which are given in the conditioning regimen. And there comes the success rate of transplant which became. So transplant has to be kept in mind from the first transfusion to the thalassemic kid, and it has to be planned beforehand so that they go to the transplant safely. Thank you.
So next question is, what is the current status and gene therapy trial for thalassemia, and what are the potential benefit and risk?
Yeah, thank you so much. This is also something which needs to be discussed. Currently, many gene therapy trials are going on in the Western world. Problem is that Western world, they don't have thalassemic kids. Thalassemia is more prevalent in the countries which are non-affluent or developing countries like India, Pakistan, Asian and African countries. That is why trials are little slow. Second thing, it requires some time for the success rate. You give the lentivirus or other viral vector, read the gene, but what it will cause to your body, that can be assessed only over the period of time. That is why, though data is maturing, data is promising, it can't be out by the time it is full proof. And it will take at least 3 to 5 years more by the time it will be fully mature and it will be clinically relevant. Yes, we all are looking forward. It looks like a easy way forward when it comes to the thalassemia, gene editing therapy, or even some other genetic disorders also. Gene therapy is something which is very promising for sure. Thank you.
Thank you, sir. There is one last question for our audience. Are there emerging trends in combining different treatments modality for thalassemia?
Yeah, very important question. Many of the parents come. Combining various treatment modalities means in allopathy, yes, we combine all the modalities and give them like better transfusion, better chelation, better supportive care, and as early as possible go for the transplant. Combining doesn't mean that you combine allopathy, Ayurvedic, some other Unani medicine, some homeopathic medicine. They are not tested, they can't be trusted. They are already the iron overloaded. And if you give something which is toxic to the liver, toxic to the kidney, toxic to the brain, toxic to the myocardium, it can be detrimental. So, combining, but wisely combining of these treatment modalities, that is what is suggested. Thank you.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. And before concluding today's session, sir, any last remark from you?
So thank you IGCP group and thank you everyone who has attended. This is on the website. You can uh, revisit this thing whenever you permit the time. Next time we will come with something like thrombocytopenia approach, which will be more useful to everyone as a clinician. And this is all from me. Thank you.
Thank you, sir, for joining us today. And with your permission, sir,